right, so as part of the CME criteria, please be aware this is a CME accredited event. There are no commercial sponsors of this grand rounds. Disclosures were reviewed and no conflicts of interest were found. Okay, our presentation today comes from Matthew Swallow. Matthew grew up in Salt Lake City, Utah, and attended college at Columbia University, where he studied biology and was a member and team captain for the men's swimming and diving team. While attending medical school here at Yale, he became interested in urology and has worked with Dr. Sprinkle studying the role of multiparametric MRI in prostate cancer screening and diagnosis. During the last year, he has also explored entrepreneurial interest and co-founded a startup that uses artificial intelligence to screen medical trainees for depression. I hope you've got your privacy settings down. I don't want you testifying in front of Senate anytime. So outside of the hospital, Matthew enjoys athletics, cooking, and travel. He's done a great job on service over the last 3 weeks. He'll be at St. Raphael's next week. And today he'll be presenting on the horseshoe kidney and its implications for renal stone disease.
Thank you for the introduction, Dr. Motamedinia. I'm excited to speak today on the horseshoe kidney and its implications for renal stone disease. I have no financial disclosures. This presentation starts with a seemingly innocuous yet pervasive chief complaint of abdominal pain in a child. Specifically, the urology team was consulted to the ED for a 5-year-old boy who presented with 1 day of left lower quadrant abdominal pain. He also demonstrated nausea and had 3 episodes of clear emesis prior to arrival at the ED. His mother denied the patient having fever or chills. In the ED, his vitals were stable. On physical exam, he was noted for abdominal guarding and tenderness bilaterally in the lower abdominal quadrants, but worse in the left lower quadrant. His labs were remarkable for an elevated white count. His urine analysis was negative for nitrates or leukocytes, and his basic metabolic panel was still pending. He also had urine collected for culture. Given his clinical picture, the ED was initially concerned for intussusception, so the patient was sent for an abdominal ultrasound. Here's an image from the abdominal ultrasound. What they found was no evidence of intussusception, but instead they found that the patient had a horseshoe kidney. You can see the isthmus crossing midline here. Here's another image from the abdominal ultrasound, which displays the left kidney with severe hydronephrosis. Given the child's elevated white count and abdominal pain, there was concern for pyelonephritis. The patient was started on antibiotics and admitted overnight. By the morning, the patient's abdominal pain had improved and a BMP showed a normal creatinine level. The patient was discharged with a plan to continue antibiotics until urine culture results returned and to get a follow-up VCUG and MR urogram. I found this patient particularly interesting, and I was drawn to learn more about how workup and management differed for common urologic ailments in patients with horseshoe kidney. As a general overview, the horseshoe kidney is the most common renal fusion variant, with a prevalence of about 1 in every 400 births, or 0.25%. It is notably more common in males, with a ratio of 2 to 1 for males to females. The most general anatomical difference in horseshoe kidney is the presence of an isthmus that connects 2 separate renal units. The isthmus can be composed of either functional renal tissue or fibrous connective tissue. Most often, the separate renal units have their own draining system. In order to understand the horseshoe kidney, it is important to review normal kidney embryology. There are 3 excretory systems that develop in human embryos. First is the pronephros, a transient and non-functioning system that regresses early during development. Next is the mesonephros, a semi-functional system consisting of 20 paired tubules that eventually fuse with the cloaca to contribute to the formation of the bladder, and in males contributes to the genital system. Finally, the metanephros forms by week 5 or 6 of embryogenesis and eventually matures into the permanent kidney. The metanephros forms in the pelvis and rises to the kidney's eventual caudal position by week 8. Horseshoe kidney occurs when the metanephric blastema fuse before ascent from the pelvis. Recently, a molecular basis for horseshoe kidney formation was proposed by researchers at Washington University in St. Louis. The researchers created mice embryos in which they directed apoptosis in the cells of the floor plate and notochord, which resulted in kidney fusion. To further investigate whether certain genes were responsible for kidney fusion, they also selectively knocked out the sonic hedgehog gene in the notochord and floor plate, which also resulted in kidney fusion. This new model not only demonstrates the importance of the notochord and floor plate in normal kidney development, but also provides an explanation for why there is a higher rate of horseshoe kidneys seen in those with vertebral and neural tube defects. The fully developed horseshoe kidney has several key anatomical differences in comparisons to normal kidneys, which have important implications for clinical presentation as well as clinical management. First, during the rise of the kidneys from the pelvis, the horseshoe kidney isthmus is caught at the inferior mesenteric artery. This results in a low-lying kidney in comparison to normal kidneys. Second, the isthmus of the horseshoe kidney causes the kidney axes to point medially, as opposed to normal kidneys which point laterally. Third, during normal kidney ascent from the pelvis, the kidneys develop several small feeder arteries off of the aorta. Normally, these arteries naturally regress as the kidneys rise to their final position in the retroperitoneum. However, given horseshoe kidneys' aberrant ascent, horseshoe kidneys often maintain multiple renal arteries that arise directly off of the aorta. All these anatomical changes are especially important to note when trying to gain access to the kidney surgically. Finally, another key anatomical difference is the high insertion of the ureter into the renal pelvis, and that the ureters course anteriorly over the isthmus. These changes are noted to lead to a higher chance for urinary stagnation, infection, and ureteropelvic junction obstruction. Of note, 80% of children with horseshoe kidney demonstrate hydronephrosis, as seen in our consult patient. However, what I found to be the most striking consequence of horseshoe kidney was the associated high rate of renal stone disease. A meta-analysis conducted by Pawar et al. In 2018 analyzed the stone disease incidence and composition of individuals with horseshoe kidneys. This study involved 14 observational studies with 943 total patients. The estimated pooled lifetime incidence of kidney stones in horseshoe kidney patients was found to be an impressive 36%. This translates to roughly a 3 to 4 times increased risk in comparison to the general population. The analysis also tracked the composition of stones for those with horseshoe kidney. Their findings demonstrated a similar relative frequency of stone composition in comparison to patients with normal kidneys. Overall, calcium oxalate and calcium phosphate were the vast majority of stones, with calcium oxalate stones accounting for 66% of all stones and calcium phosphate accounting for 19%. So in summary, the horseshoe kidney has a strong effect on the frequency, but not necessarily the composition of stone disease. Recently, there has been a debate regarding the etiology of stone formation in the horseshoe kidney. The traditional explanation for high rates of stone disease in horseshoe kidney patients was that the high insertion of the ureter and the ureter's course over the isthmus leads to urinary stasis and increased infection, ultimately leading to higher rates of stone formation. However, a study conducted at Duke in 2004 investigated the role of metabolic abnormalities in stone formation for horseshoe kidney patients. Their study was a retrospective review for 10 years of all horseshoe kidney patients at Duke and Wake Forest with renal stone disease. 11 horseshoe kidney patients with complete metabolic workups were identified and included in the study. Serum and urinary chemistries were then compared between horseshoe kidney patients with renal calculi and age, sex, race matched controls with normal kidneys and renal calculi. They found that all horseshoe kidney patients had at least one metabolic abnormality in their 24-hour urine collection. The most common abnormalities were low urine volume, hypercalciuria, and hypocitraturia. Similar rates of metabolic abnormalities were noted in renal calculi patients with normal anatomic kidneys. What emerges from this study is a multifactorial picture with metabolic abnormalities as well as increased urinary stasis playing a role in renal calculi formation. On the basis of these results, the researchers recommended that all horseshoe kidney patients with renal calculi undergo a metabolic evaluation for possible medical prevention of future stones. Given the high prevalence of stones in those with horseshoe kidneys, it is also important to understand if the horseshoe kidney affects the treatment approach for stone removal. In general, the horseshoe kidney does affect treatment choice, but the 3 main surgical treatment options for normal kidneys, consisting of shockwave lithotripsy, retrograde intrarenal surgery, and percutaneous nephrolithotomy, are the same as those used for the horseshoe kidney. Extracorporeal shockwave lithotripsy is often considered the first-line surgical treatment for smaller kidney stones. However, there have been concerns that shockwave lithotripsy is less effective in the horseshoe kidney. Specifically, the abdominal location of the horseshoe kidney leads to a greater skin-to-stone distance, and the often impaired drainage system in the horseshoe kidney decreases the chance for disrupted stone fragments to exit the collecting system. A study conducted at the University of Toronto in 2011 sought to analyze the success rates for shockwave lithotripsy in horseshoe kidney patients. They performed a retrospective review for 18 years of patients with horseshoe kidney at their institution who were treated with extracorporeal shockwave lithotripsy. Full data was available for 29 patients over that time period. The mean size for the treated stones was 1.1 centimeters, and almost all patients required at least 2 treatment sessions. The researchers followed up with their patients and defined success as an asymptomatic patient with residual stones less than or equal to 4 millimeters. Stone-free rates were defined as a clear kidney on follow-up imaging. At 3 months, their overall success rate was 63.6%, and they achieved a stone-free rate of 39.1%. In comparison to the estimated 90% success rate for shockwave lithotripsy in normal kidneys, this study demonstrates a technique's comparatively lower success in horseshoe kidney. This data is also notable for the difference between success rate and stone-free rate, and that a sizable proportion of stones fail to pass after successful fragmentation, suggesting that disrupted stones have difficulty exiting the impaired collecting system. However, one notable critique was that this was a single-center study. The study was conducted at a known referral center, and their data may have been biased as patients with positive outcomes may have been lost to follow-up, and their hospital itself may see a higher rate of more complex stone patients. Just as the horseshoe kidney presents challenges for shockwave lithotripsy, notable impediments associated with retrograde intrarenal surgery in horseshoe kidney patients include higher ureteral insertion into the renal pelvis and often tortuous ureter. Given that these two treatment modalities are considered less invasive methods for stone treatment, it is important to understand the difference in outcomes for horseshoe kidney patients receiving either treatment option. A retrospective study published in 2016 compared outcomes for shockwave lithotripsy and retrograde intrarenal surgery in horseshoe kidney stone patients. Both treatment groups were similar demographically in respect to age, gender, and stone location. Both groups had a mean stone size of 1.7 centimeters. Their primary outcomes were measured as stone-free rate, defined as no residual fragments greater than 3 millimeters, renal colic episodes, and complications. What they found was that overall, retrograde intrarenal surgery outperformed shockwave lithotripsy. The stone-free rate in retrograde surgery was 73.9%, while the shockwave lithotripsy success rate was 47.7%. Furthermore, renal colic episodes were found in only 13% of those receiving retrograde surgery, in comparison to 36.3% in shockwave lithotripsy. Complication rates for both procedures were similar at 18%. Furthermore, the need for general anesthesia is often a quoted risk for retrograde surgery and is used as a rationale favoring shockwave lithotripsy. But in this study, there were notably no complications from anesthesia. Getting access to the kidney percutaneously can be challenging, and careful review of kidney positioning, orientation, blood supply, and adjacent organs is necessary. However, it is still viewed as the gold standard for stone treatment in horseshoe kidney patients, especially for those with a stone burden greater than 2 centimeters. A study published in 2008 commented on their institution's outcomes for percutaneous treatment of horseshoe kidney renal calculi. Typically, they observed percutaneous treatment for patients with heavy stone burden. The overall number of horseshoe kidney patients treated percutaneously over a 15-year period was 47. The treated stone size had a very large range, but the mean size was 2.8 centimeters. Overall, the researchers found very good results for those patients. Success rates results similar to those with normal kidneys. Approximately 80% required only 1 treatment for stone clearance, and nearly 100% of patients were stone-free after 2 treatments. Complication rates were also relatively low, with an overall complication rate of 20%. 13% of those receiving 1 stage for stone removal encountered a minor complication, and none had a major complication. Those receiving 2-stage removal had a 16% chance of a major or a minor complication. Overall, percutaneous nephrolithotomy is associated with a very high rate of success for stone clearance and should be the first-line treatment for complicated stone patients. This brings us to the conclusion of the presentation. In summary, while the horseshoe kidney is most often diagnosed incidentally and is asymptomatic, those with a horseshoe kidney are at higher risk for renal stone disease. Furthermore, stone disease etiology in horseshoe kidney patients has been suggested to be multifactorial, and a metabolic workup is warranted in horseshoe kidney stone formers to see if they would benefit from medical stone prevention. Finally, while treatment choice should be tailored to the individual, both retrograde intrarenal surgery and percutaneous nephrolithotomy have demonstrated superior outcomes for stone disease in horseshoe kidney patients. The horseshoe kidney is an excellent example of how a small embryologic anomaly can lead to downstream sequelae, how anatomic defects drive physiologic change, and presents an interesting context with which to critically evaluate minimally invasive surgery. I just want to acknowledge a few members of the audience for their help in creating this presentation. First, I'd like to thank Resident Dr. Casey Nawaf for taking me to the consult and discussing the case with me. Second, I'd like to thank Dr. Motamedinia for organizing the sub-internship, as well as helping me select and refine my presentation. And finally, I wanted to thank the Yale Urology Department for taking me this month, for providing me with a fantastic sub-I experience so far. Here are some of my references. I'd be happy to take any questions. Yeah, so I looked into the chart, and so far they haven't gotten either study done yet, and they're planning to follow up with the Yale PD Urology Department.
I assume is because it looks so dilated, UPJ is a diagnosis, and it's kind of chicken or egg. Does he have a stone at the UPJ, or does he have a stone causing the UPJ? I mean, I think we're seeing an increased number in stone overall in pediatric patients, and there's a higher risk of stone formation in horseshoe kidneys. But I would have been surprised when he walked in that this was a stone. That would have been my first thing on the diagnosis. Most likely UPJ, yeah. Oh, I thought, okay, so there was no diagnosis of stone in the end? Oh, okay. Yes, he has UPJ. Gotcha.
He just has a UPJ. He doesn't have the stone, that patient. Just starting to be worked up within the last week.